Namaste. Welcome to a Heartbeat episode, and today we are here to discuss one of the important rhythm disorder. And this rhythm disorder is somewhat silent in many patients, and this is one of the rhythm disorder which is associated with stroke. Means if you are having this rhythm disorder, the chances of a stroke is bit high, and that's why it become very important that we should know in and out about this disease when you have been diagnosed. So this disease is called atrial fibrillation. So as a rhythm specialist, my perspective of this disease is totally different, and we treat in and out about this rhythm disorder, in which first we have to label the patients. So atrial fibrillation, when we are saying, means it is a rhythm disorder, and the only investigation what we need is the ECG. And when it is of three variant: paroxysmal, persistent and permanent, or we can say chronic. So these three variants we label depending upon the time. Means when it is happening for some time and going, we call as a paroxysmal, and when it is persisting for some days, we say it's a persistent. Sometime it needs the defibrillation or medication to revert to the sinus rhythm, and third is the permanent, means it is all the time ongoing. So the timing is the way we classify this atrial fibrillation. Means if you are having paroxysmal, persistent or permanent or chronic atrial fibrillation, means you are a patient of atrial fibrillation, that we have to understand. And next comes the most important, whether you are symptomatic or asymptomatic, means you are having any symptom related to the heart disease or not. What is your risk of developing a stroke? So even though you are asymptomatic, means you are not having any symptom, it is better to know the risk, and we do the risk scoring by one scoring system we call it CHAD-VASc scoring. This is a very time tested risk scoring system. Even you can just see in the comment box you will be getting. In that you can still decide whether you are having these risk factors or not. You are having diabetes, you are having hypertension, heart failure, or you are having age less than 65, more than 65, or vascular disease. On that we decide the patient is having risk scoring which give a risk higher for developing a stroke, and it is told that if your risk is more than 2 or 2 without taking the sex as a one of the or gender as one of the component, you are a candidate for going for we say anticoagulant therapy. Means atrial fibrillation risk means anticoagulation, and this anticoagulation is a lifelong medication. Means if you have been diagnosed with atrial fibrillation, the next important thing we have to see whether I qualify to take the anticoagulant or not to reduce the risk of a stroke. So that is called holistic approach for atrial fibrillation. Means diagnosis of atrial fibrillation followed by medication need is there or not. If you are symptomatic, certainly we have to give some other medicines like beta blocker, calcium channel blocker, or some antiarrhythmic. Those medicines are the part of the treatment of your symptoms. But when we are giving anticoagulant, we are giving medicine to prevent the stroke. So stroke is the most notorious thing in a disease of atrial fibrillation that we have to prevent, and before it strikes, you should take the medicine so that you can reduce the risk. But this CHAD-VASc scoring, what I told right now, is not applicable in particular situations. So if a patient is having valvular heart disease like mitral stenosis, or patient is already on the valves, or patient is having hypertrophic cardiomyopathy, or patient is having amyloid heart disease, these are 4 conditions where we don't do CHAD-VASc scoring. If you are diagnosed any time atrial fibrillation, you have to put the patient on the anticoagulant, and these patients will be on this medication lifelong. And if the symptoms are coming, then we have to give the other medicines starting from beta blocker, calcium channel blocker, or even antiarrhythmics depending upon your type of risk factors or type of your profile, means how the echo and how the other risk factors are. This is one treatment. This is called tier 1 treatment. Usually a question arises whether we should go for ablation or not, and this is a very big area of intervention for the interventional electrophysiologist. If you go and see in the worldwide like US and Europe, they do a lot of ablation in this type of patient, but there is one truth that we have to accept, that this is not a curable condition. So whatever ablation we are doing for other arrhythmias and for the atrial fibrillation, it is a different. Now coming to the role of ablation, radio frequency ablation, cryoablations. These are two treatment strategies that we advise to the patients. But before going in detail, let me make some clarity regarding, because a lot of time patients are not knowing why they are going for the procedure. So medicine is the first, lifestyle medicine, followed by anticoagulation treatment, whether you qualify or not, and second comes the intervention for atrial fibrillation. So the first interventions most of the time worldwide is the PVI, pulmonary vein isolation, or we can say EP study, RF ablation. And sometimes the other component means one time we are giving the heat energy, we call it a radio frequency ablation. Now coming to the second part, that is the interventional treatment of atrial fibrillation. So in interventional treatment, we are having two type of treatment, what we call as a radio frequency ablation, and second is called cryoablation. So these are two evolved treatment, and it is worldwide practiced for the atrial fibrillation. But before going into detail, let us understand why we are doing and what we are going to gain by doing the interventions. So ablations, radio frequency ablation, what we do for the arrhythmias, there are some treatments in which we are providing the curative treatment, means the time we are doing like a PSVT patient, AVRT, AVNRT, these are the on and off palpitations, and by ECG we can label it, and later on we will confirm and ablate, and finally the patient is cured, means the patient is out of the medicines or he is totally out of the doctor's review also. But there are some diseases like atrial fibrillation. Medicines, we are going to control the symptoms. With anticoagulation, we are going to reduce the risk of stroke. But if the patient is having on and off atrial fibrillation is going, the frequency is more. If we are doing the radio frequency ablation, we are reducing the burden of the disease, we are reducing the frequency of the disease. But here we are not curing the disease. So if you are going with the notion that probably if RF ablation I am doing, my disease is cured, it is not at all. It is only the reduction of your frequency. If it is happening 5 or 7 times in a year, it may be possible that it may reduce to 2 or 3 with medicines and with RF ablation. So cryoablation and RF ablation, these are two modes of ablation procedure which we do. In cryoablation, we are freezing the pulmonary veins. So we are putting some balloon and we are freezing and making that it is not going to incite the atrial fibrillation. And in other, we are just isolating, means we are giving a point-to-point ablation in particular location of the pulmonary vein, because pulmonary vein is taken as one of the inciting component of the atrial fibrillation. Means some stimulus come from the pulmonary vein and that incite the atrial fibrillation. This is the foundation on which we treat this thing. But even though after doing the ablations, the patient can still develop by the other ways, means there are other components of the atrial fibrillation substrate. So those are very different areas. I don't want to go in depth on those topics. But if the patient are not going for this procedure, whether they can still continue on medicine, yes, you can still continue on medicine, and you are having two options. One option is ablation if you want to reduce the frequency of disease or tempo of disease, and second is if the patient is developing on and off this type of high heart rate, means the patient with atrial fibrillation will be coming to the hospital with very high ventricular rate, means the heart rate is going 170, 200 in between. In that situation, the second option is you have to disconnect the upper and lower chamber, what we call as AV junction ablation, followed by pacemaker. So if you do it, the chances of high heart rate will be low, high heart rate will be totally taken off, and you can still live the comfortable and asymptomatic life on medicines. So these are the two modes of treatment. Coming to the third thing, third component, a lot of patients say that I don't want to take medicines, I want to go for the left atrial appendage closure. So this is also one of the treatment where we are going to stop the anticoagulation after putting the left atrial appendage, because it has been seen that 90% of the patient develop the clot in the left atrial appendage, which is the reason for developing a stroke, and these strokes are the bigger stroke. So one treatment strategy has been evolved over time, that if you are going to close this small chamber in the left atrium, which is called left atrial appendage, the chances of a stroke will be less. But I will say still this treatment has not been well established. It has got a lot of ifs and buts. It is having its own complication, and it has not been well proven to say that it is going to take out all the anticoagulant. In selected patient, yes, it can be done, but in the medical parlance, we use the what is called consensus class 1, class 2, class 2A and B, like that. So it is never been a class 1 indication. Means if you are thinking that I want to take out my anticoagulant and blood thinner which lead to the bleeding type of stroke, I should go for it. I will strongly recommend not to go for it because it has got its own indication. If you are developing on and off GI bleeding, or you are already having a bleeding stroke in which you can't give, this type of treatment can be given, but not in the routine cases. So it is for the only a very niche selected patients in which the left atrial appendage with an anecdotal result can be accepted. So it is not a very good therapy. Your therapy is first anticoagulation with symptomatic treatment for the beta blocker, all those, so that the tempo of disease, or the frequency of disease you can reduce. If it is happening time and again, then you have to go for the ablations, and sometime if the patient is not ready for ablation, antiarrhythmic can be given, and that can reduce the disease. If it is not working, the third line of treatment is AV junction ablation and pacemaker. And if you really want to come out of means GI bleeding, if you have already happened, or if you are having stroke which is a bleeding stroke, then left atrial appendage can be one of the choice to be made. So with this information, we will meet you next time with some important, interesting topic. And not to forget, if you are having any questions, query, kindly post in the comment box. Thank you so much. Namaste.